This presentation will cover the respiratory system. Of the 11 body systems, the respiratory system is the one that is responsible for breathing. We will first introduce the anatomical parts of the respiratory system, and then move our way into a little bit of respiratory physiology, and also talk a little bit about spirometry. Just as all of our 11 body systems do, the respiratory system's roles are vital for the homeostasis of the entire body. One of the systems in particular that the respiratory system works so nicely with is the cardiovascular system. As we've just talked extensively about the heart, the blood vessels, and the blood itself, we're now going to see how the respiratory system continually supplies oxygen to the cardiovascular system. That, in fact, was one of the major goals of the cardiovascular system, to carry oxygen out to our body tissues. And while the cardiovascular system's roles are quite magnificent, the jobs that system carries out are completely contingent on the respiratory system. So we're first going to introduce all of the anatomical parts of the respiratory system, and once we have made our way down the respiratory tree, we will then start to talk about how the lungs will facilitate respiration. The gross anatomy of the respiratory system includes all of the structures that we use to breathe. The respiratory system is an open cavity, and therefore it's lined with a mucous membrane. All of the structures that will convey air into the lungs are considered a part of the respiratory system. We will work our way back to the lungs. The first component of the respiratory system is the nose and the nasal cavity. This space connects the external environment with the structures that will bring air into the lungs. As the nasal cavity makes its way back down to the back of the throat, we'll enter into the pharynx. The pharynx sits just superior to the larynx, and it is these two terms that, based on their spelling and the way that they sound, are often confused. The pharynx will always be superior to the larynx. The pharynx can more commonly be referred to as the throat, while the larynx is more often referred to as our voice box. It is here in the larynx where we can phonate, or produce sounds and speak. The pharynx is truly going to belong to both the respiratory system and the digestive system, as food will need to pass through the pharynx to be swallowed. But as we make our way down to the larynx, this is primarily going to take air into the respiratory system. Our vocal folds that we'll use for speaking are found in the larynx. The larynx sits just superior to another structure known as the trachea. The trachea is wrapped in different cartilaginous rings that are shaped like the letter C. These cartilaginous rings provide protection for the trachea and keep it open. The trachea will eventually bifurcate into two different bronchi. If we refer to these singularly, they are called a bronchus, but plurally we'll call them bronchi. There's a right bronchus and a left bronchus, and each bronchus is the tube that allows air to flow into the lungs. We will see the respiratory tree and how it's arranged very shortly. Probably the most familiar component of the respiratory system are the two lungs. We have a right lung and a left lung, and each lung will sit right on top of the diaphragm with the heart sitting right between them. Each lung contains lots of pulmonary capillaries and will inflate with air when we inhale. The oxygen that's brought into our lungs will diffuse across the respiratory membrane and go into our bloodstream so that the cardiovascular system can transport that oxygen out to our tissues. Now, while we have spoken about the more popular structures that make up the respiratory system, we don't want to forget the diaphragm. The diaphragm is often referred to as our muscle of breathing. The diaphragm is a muscle that's shaped like an upside-down bowl. And since we know that muscle contracts and that shortens its length, when the diaphragm contracts, that flattens out the diaphragm. Because the thoracic cavity, which contains the lung, is not open to the outside environment, when the diaphragm flattens out, that's going to increase the total space that is in the thoracic cavity. However, at the same time that this happens, since this is a closed cavity, the pressure will drastically decrease, and it is pressure gradients that we will see here in the respiratory system that will facilitate ventilation, which is just a fancy word for breathing. So it is these that are the major components that make up the anatomy of the respiratory system. Every component in this system carries out its own unique roles. However, the roles of every individual component will all work towards the same goal of bringing air into the lungs and re-oxygenating our blood. The larynx and the trachea are protected by cartilage. The larynx in particular has 9 different pieces of cartilage. There are 3 pieces of unpaired cartilage and 6 pieces of paired cartilage. The 3 unpaired cartilages are shown. We first see the epiglottis, which can be found here. We'll find our thyroid cartilage, which which sticks out here, and we'll find the cricoid cartilage, which can be found inferior to the thyroid cartilage. The epiglottis is one of the few structures in our body that's made up of elastic cartilage. The epiglottis is a little flap that will sit over the opening to the respiratory system. This is a very useful structure, as it is the epiglottis that keeps food from entering into the respiratory system. Since the opening of the digestive system and the respiratory systems are right next to each other, we need to have a mediator that keeps solid substances out of our respiratory system and going into the digestive system. We'll also find the thyroid cartilage, which can be found right here. The thyroid cartilage contains a structure known as the laryngeal prominence, as it is part of the larynx. The laryngeal prominence is also colloquially known as the Adam's apple. The cricoid cartilage can be found just below the thyroid cartilage down here. So it is the epiglottis, the thyroid cartilage, and the cricoid cartilage that are singular structures and therefore can be described as unpaired. One other structure that we see in the larynx is the hyoid bone. The hyoid bone, which we can hopefully remember from Anatomy and Physiology 1, is a very unique bone that's shaped like a horseshoe. The hyoid bone is the one free-floating bone in the entire body, and therefore it doesn't articulate with any other bones. That does not mean, however, that nothing attaches to the hyoid bone. The hyoid bone serves as a location for muscle tendons to come and attach to, especially for the muscles that are used for swallowing. We'll also come to find that this membrane shown here that attaches the hyoid bone to the thyroid cartilage is known as the thyrohyoid membrane. This is quite an appropriate name, as it incorporates the two structures that are connecting to it. We'll also find this little membrane down here, known as the cricothyroid membrane, as this will be the membrane that connects the cricoid cartilage to the thyroid cartilage. Remember, the larynx is referred to as the voice box, so it is inside of the larynx that we'll have our vocal folds that help us to speak. So we do have 9 cartilages. The epiglottis, the thyroid cartilage, and the cricoid cartilage are the first 3 cartilage that are unpaired. However, the other 6 are paired, which means that there's going to be one on either side. We will refer to the sagittal section to view these 6 paired cartilages. Remembering that there is one of these on each side accounts for the other 6 cartilages to give us a total of 9. Specifically, we'll find the cuneiform cartilage, the corniculate cartilage, and the arytenoid cartilage. The cuneiform cartilage, which can be found right here, is supportive to the folds that can be found in the larynx. We'll also find our corniculate cartilage, which gets its name because it looks like a corn kernel. Lastly, the arytenoid cartilage is roughly pyramidal in its shape. The vocal cords attach to the arytenoid cartilage, and these will help the vocal cords move. From this view, you can see the epiglottis, which is elastic cartilage, the thyroid cartilage, which can be found here, containing the laryngeal prominence. You've got the cricoid cartilage and the membranes that sit between them. You have your hyoid bone, which can be found up here, the cuneiform cartilage, the corniculate cartilage, and the arytenoid cartilage. Now there is one more type of cartilage that I have left out, and that type of cartilage is known as the tracheal cartilages. The tracheal cartilages are the ones that are shaped like the letter C. These will wrap around the trachea, and you can feel these tracheal cartilages on your own trachea. This slide shows us a superior view of the trachea and the esophagus. The esophagus is part of the digestive system, and when we swallow, food goes into the esophagus. You can see how closely this is associated with the trachea. It is the trachea that will convey air into the lungs. And because it is the function of the trachea to allow air into the respiratory system, we need to make sure that the trachea stays open as to not block the airway. And this is the job of the C-shaped cartilaginous tracheal rings. You can see that the tracheal cartilage is depicted in blue here. Because of the shape of the tracheal cartilage, this keeps the airway patent or open. And this assures that our airway will not close when we relax our muscles or lose muscle tone when we sleep. As we're getting ready to bring food back into the esophagus, the epiglottis will close over the trachea, and that will allow for food to pass by the trachea and into the esophagus. But even during swallowing, it's the epiglottis that sits over the trachea. The tracheal rings never in fact close. So if we include our tracheal cartilages, that is a 10th type of cartilage that we'll see in the respiratory system thus far. So now we'll see how each of these respiratory structures look on the cat. The larynx can be found most superiorly just at the top of the neck. We've seen now that the larynx connects to the trachea, and you'll actually be able to see the cartilaginous tracheal rings that hold the trachea open. The trachea will eventually split into two bronchi, and those bronchi will eventually split themselves. But ultimately, air that passes through the trachea will make its way out to the right and the left lungs. You can see the right and left lungs on either side of the heart. Those are found in the thoracic cavity. One thing that you might remember about the heart is that the heart is found slightly on the left side, and therefore the left lung will be slightly smaller than the right lung. In fact, the left lung has 2 lobes, while the right lung will have 3. Separating the thoracic cavity from the abdominal cavity is our muscle for breathing, the diaphragm. And just below this, we'll see the liver and our other organs of digestion found in the abdominal cavity. Referring once again to the shape of the diaphragm is shaped like an upside-down bowl. And you can really see that here on this slide as the diaphragm separates the thoracic cavity from the abdominal pelvic cavity. When the diaphragm flattens out, that's going to open up the thoracic cavity and allow air to flow into the lungs. In this picture, we have zoomed in to see the larynx of the cat. The laryngeal prominence indicates that we're looking at the thyroid cartilage, and we know that by looking at the thyroid cartilage that the cricoid cartilage will always be found right below it. In between the two, right here, will be the cricothyroid membrane. Just below the cricoid cartilage, the larynx will end, and that will take air into the trachea. And you can see these lines that will indicate that we're looking at those tracheal rings. Those, again, are shaped like the letter C, and they keep the trachea open at all times. So now that we've discussed all of the components of the respiratory system and the cartilages that make it up, we're now going to transition into respiratory physiology and spirometry. Spirometry is a way that we can measure lung function, the amount of air that can be inhaled or exhaled. As we've now talked about the components of the respiratory system, we're now going to see how they all work together to facilitate ventilation and respiration. As air makes its way down the trachea, it's going to go in either the right bronchus or the left bronchus. Each bronchus will split again into what are known as lobar bronchi, and each lobar bronchi will split into segmental bronchi. We often refer to the bronchus as the primary bronchus, the lobar bronchus as the secondary bronchus, and the segmental bronchus as the tertiary bronchus. Eventually, these tubes are going to become smaller and smaller and end up at little sacs known as alveoli. The lung is filled with alveoli, and those are the containers that hold air inside of the lung. Before we move to the next slide to discuss the alveoli, I just want to show you once again that the right lung will have 3 lobes: a superior lobe, a middle lobe, and an inferior lobe, and the left lung will only have 2, specifically a superior lobe and an inferior lobe. The left lung is only going to have 2 because there's less space for this lung to exist on the left side, as the heart is slightly moved towards the left side of the chest. But moving on with the respiratory tree, we will see that after the tertiary bronchi, we're going to eventually have terminal bronchioles. Terminal bronchioles will eventually split into alveolar ducts, and then the alveolar ducts will convey air into the alveoli. Alveoli are like tiny little balloons that inflate with air when we inhale. Alveoli are often clustered together, and we call one of these clusters an alveolar sac. It is the alveoli that are very, very closely associated with the pulmonary capillaries. You can see this picture will demonstrate this phenomenon. The blue pulmonary arteries are going to take deoxygenated blood out to the pulmonary capillaries, and the pulmonary capillaries are going to be very, very closely associated with the alveoli. You can see the pulmonary capillaries engulfing the alveoli. And it is at this location that we'll find the respiratory membrane and transition that blue deoxygenated blood into red oxygenated blood with the oxygen that's coming into the respiratory system through the alveoli. It is the walls of the alveoli and the walls of our pulmonary capillaries that will make up what we know as the respiratory membrane. The respiratory membrane is a very thin layer, and it facilitates gas exchange for oxygen to enter into the blood and carbon dioxide to get offloaded back out into the lumen of the alveoli. This picture will demonstrate this phenomenon. As air is pulled into the alveoli, oxygen in the air is going to come into the lumen of the alveoli specifically. As air is pulled into the alveoli, oxygen in that air is going to be in high concentration here in the lumen of the alveoli. Deoxygenated blood specifically is coming back from the pulmonary arteries. So there's a concentration gradient for oxygen that is set up pointing into the bloodstream. Oxygen will then be able to flow through that thin respiratory membrane and re-oxygenate the red blood cells as it makes its way back to the left side of the heart. At the same time, carbon dioxide is going to be in high concentration as it is a waste byproduct of metabolism. So the red blood cells coming back to the pulmonary capillary will have a very high concentration of carbon dioxide, and air coming in has a very low concentration of carbon dioxide. Therefore, we have another concentration gradient for carbon dioxide that is set up pointing from the blood into the alveoli. So we will have the diffusion of these two gases in these two directions. This is another picture to show this phenomenon. Now, I also want to take a quick second to describe the difference between the terms ventilation and respiration. Ventilation is just a fancy word for breathing. The action of pulling air into the lungs and expelling air out from the lungs is ventilation. Respiration more specifically refers to the actual gas exchange that takes place. This process shown here in the pulmonary capillaries is referred to as external respiration, because it includes gas exchange with the external environment. Internal respiration is what will take place in our systemic capillaries, where oxygen diffuses out of the capillaries and into the tissues, and carbon dioxide diffuses from the tissues into the blood. So we're now going to take what we know about ventilation and utilize spirometry to assess the health of our respiratory system. A spirometer is a device that measures the amount of volume that is coming in and out of the lungs during inspiration and expiration. We refer to the volumes that the spirometer measures as simply the respiratory volumes. By measuring these volumes, this gives us a way to measure the health of the respiratory system. There are set amounts of volumes that can come in and out of the lungs. And what we tend to find with respiratory diseases is these volumes end up changing. So the spirometer is a fantastic tool that we can use for pulmonary function tests. We have one other concept that we're going to introduce, and those are the respiratory capacities. Capacities are simply combinations of different lung volumes. We can add up the total amount of volume that we can expire and inspire, along with a few others, and that gives us what's known as our total lung capacity. There are 4 respiratory volumes, namely the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and the residual volume. And we'll also have 4 capacities, specifically the inspiratory capacity, the functional residual capacity, the vital capacity, and the total lung capacity. We can use the volumes to calculate what the different capacities are. And depending on which of the volumes and capacities are available, we can also calculate certain lung volumes if we're not given those values. So let's take a look at the spirometer and then start to break down the respiratory volumes and capacities. First and foremost, this picture shows us what a spirometer is. It's actually quite a simple device. It has this long tube, and when you breathe into the tube, that's going to make this little white box in here rise. This white box is attached to this scale, and this will tell you the amount of volume that is under the white box. So despite its simplicity, the spirometer is an extremely useful piece of equipment. So the respiratory volumes include the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and the residual volume. Each of these have a very nice abbreviation, which is the first letter of each word that makes them up. The tidal volume gets the abbreviation TV, inspiratory reserve volume gets the abbreviation IRV, and so forth. Each of these volumes are specific numbers. However, we need to define what each of these volumes are first before we can start talking about how much volume is in each one. So specifically, we'll start with the tidal volume. The tidal volume is the amount of air that is exchanged between the atmosphere and your respiratory system during normal breathing. I would expect that while you are watching this, you are undergoing normal quiet breathing. And so the air that you're normally inhaling and exhaling with a natural normal breath is considered your tidal volume. The tidal volume in both males and females is generally around 500 milliliters. That's half of 1 liter. So every time you naturally inhale to the point of comfort, that increases the amount of air in your lungs by 500 milliliters. Now we'll see here that the inspiratory reserve volume and the expiratory reserve volume are quite a bit more than just the tidal volume's 500 milliliters. The inspiratory reserve volume can be defined as the maximum amount of air that can be forcefully inspired after the normal tidal volume. This is actually a little over 2 liters, 2100 to 2300 milliliters. I like to think about the inspiratory reserve volume as the amount of volume in our lungs that is reserved for inspiration. So this would be the increase in volume that you get when you take a deep breath. Of course, a deep breath is past the normal tidal inspiration. So the tidal volume is what we can play around with when we're resting, and the inspiratory reserve volume is all the space remaining for a very forceful inspiration or deep breath. Now the expiratory reserve volume, abbreviated as ERV, is just the opposite. This is the volume that is reserved for expiration. So beyond the tidal volume, you can expire even more. You can actually exhale about an entire liter more after you have already undergone your tidal expiration. Naturally, we don't use all of our lung volume every time we're undergoing normal, quiet breathing. You can always end up taking a deep breath or exhaling just a little bit more. And that would be your IRV and your ERV. Now, our last lung volume is the residual volume, abbreviated RV. The residual volume refers to all of the amount of air that remains in the lungs after you have already forcefully expired. This essentially is the volume remaining in your lungs after you have already exhausted your expiratory reserve volume. This residual volume is worth about the same as the expiratory reserve volume at a little over 1 liter. The residual volume ensures that our alveoli remain open at all times. If our alveoli were ever to lose all of their volume, the walls of the alveoli would lay on each other and it would be almost impossible for us to pull air back into the lungs. So by keeping a little residual volume of our lungs, this maintains the patency, or the openness of our alveoli. By definition, the residual volume can never be exhaled. So at all times, whether you're expiring or inspiring, you'll always have about 1,200 milliliters of air that remains in the lungs. So by taking all 4 of our lung volumes, we get what's known as the total lung capacity. That's the total amount of air that can fit in the lungs after a forceful inspiration. The total lung capacity is just one of our 4 capacities that can be calculated using our respiratory volumes. The total lung capacity, abbreviated as TLC, can be calculated simply by adding up all 4 of our other lung volumes: the residual volume, the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. Now we'll also see that there are 3 other capacities. Again, all of the capacities are just various combinations of the respiratory volumes. The vital capacity specifically, abbreviated as VC, accounts for all of the air that can come in and out of our lungs. Therefore, we'll calculate this capacity by adding up the expiratory reserve volume, the inspiratory reserve volume, and the tidal volume. This essentially accounts for all of the volumes with the exception of the residual volume. So by this logic, we can actually also calculate the total lung capacity by knowing what the vital capacity is and adding the residual volume to it. Let's take a look at a graph that will show us all of the lung volumes and capacities all in the same place. This slide will show us just about everything we need to know about our respiratory volumes and our respiratory capacities. Let's look over here to just make sure that we have a good understanding of what these volumes are. The tidal volume is what we naturally breathe when we're resting. You can imagine this green circle either inflating or deflating based on whether we are inspiring or expiring. As we naturally inspire and expire, the tidal volume is going to be shown here. However, if we were to forcibly inspire and take a really deep breath, the volume that's remaining in our lungs is the inspiratory reserve volume. And conversely, if we were to exhale past the tidal volume, that's our expiratory reserve volume. But we want to remember there's always a little bit of volume that's left over in the lungs, and that is our residual volume. Now on this graph we can see a couple different things. First off, the y-axis shows us volume in milliliters, and the x-axis shows us time. So this is actually a spirometer tracing of someone breathing. As they are naturally breathing at rest, this is going to be their tidal volume. Eventually they're going to expire forcefully, and our spirometer tracing is going to come down here, and then we'll maximally inspire up here, and that shows us our inspiratory reserve volume. So this is how we read a spirometer tracing. It's measured in volume over time. Now you can see that it's the tidal volume that's naturally exchanged at normal breathing. This is about 500 milliliters worth of air. Both men and women will have a tidal volume of about 500 milliliters. And we'll see down here the differences in these volumes between males and females. The expiratory reserve volume is the amount of volume that can be forcefully exhaled past the tidal volume. So when we forcefully exhale, we'll see that the expiratory reserve volume will be shown here. That's going to be a little over 1 liter. And on the other side of the tidal volume, we'll see our inspiratory reserve volume up here, which is over twice as much as the expiratory reserve volume. And lastly, down here where the spirometer tracing never touches, we'll have our residual volume, which is just over 1 liter. So now that we can see where these lung volumes are on this graph, we'll also see the capacities and how we can calculate each one. Specifically, the total lung capacity includes all of the volume that can fit in the lungs at maximal inspiration. The total lung capacity in a normal male is roughly about 6 liters. You'll see here with females that it is a little bit less than this. You can calculate the total lung capacity by adding the inspiratory reserve volume, the tidal volume, the expiratory reserve volume, and the residual volume together. Now you'll also remember the vital capacity took the IRV, the TV, and the ERV and just added those 3. You can see the vital capacity is the amount of air that can naturally come in and out of the lungs. We don't include the residual volume in this because the residual volume can never be exhaled. It will always remain in the lungs. We will in fact have an inspiratory capacity and a functional residual capacity as well. The inspiratory capacity is calculated by taking the inspiratory reserve volume and adding that up to the tidal volume, and our functional residual capacity can be calculated by taking the expiratory reserve volume and adding that to the residual volume. As by its definition, the residual volume can never be exhaled, and therefore we can't assess its value with a spirometer. Now these are the normal values for respiratory volumes and capacities. However, in cases of lung disease, these volumes and capacities tend to change. One thing that we can use to assess our respiratory efficiency is calculating the minute ventilation. This can also be called the total ventilation. But I prefer to call this the minute ventilation because that tells you that this is the amount of air that's allowed to flow into or out of the respiratory system in 1 minute. This is a similar concept as cardiac output. However, this refers to ventilation and does not deal with the blood, so let's not get those confused. As with many lung diseases, minute ventilation will decrease as whatever the condition is progresses. So by assessing minute ventilation, we can really get a lot of insight as to how efficient our patient's respiratory system is functioning. 2 other pulmonary function tests that we will see is the forced vital capacity and the forced expiratory volume. A forced vital capacity, abbreviated as FVC, is when you take a deep breath and forcefully exhale all of the air in your lungs as quickly as possible. Forced vital capacities are very useful because they indicate how much resistance there is in the airway. The forced expiratory volume is an interval of the forced vital capacity. When undergoing a forced vital capacity, the forced expiratory volume tells you how much air has been expired during every second. We often note that the forced expiratory volume is given numbers such as FEV1 and FEV2. This would indicate, if we're looking at an FEV1, the amount of air that is expired in the first second, and if we're looking at an FEV2, that's the amount of air that is expired in the second second. And we see both FEV1 and FEV2 have parameters that we're going to be looking for with pulmonary function testing. So during the first second of a forced vital capacity, we should be expiring at least 3/4 of all of the air in our lungs. And by the end of the FEV2, we should have almost expired all of the air in our lungs as well. Specifically with chronic obstructive pulmonary disorder, or COPD, these numbers will be decreased. With COPD, there's increased resistance in the airway, and therefore that prevents us from expiring as efficiently as somebody with normal lungs. As you can see, the spirometer is an extremely useful tool that we can use to assess the health of the respiratory system. While the spirometer is a wonderful tool, it does have its limits, and therefore it cannot actually measure every single lung volume. Specifically, the residual volume cannot be assessed by a spirometer because, by its definition, we cannot expire the residual volume. Therefore, in order to get the residual volume, we'll have to calculate it out by having the total lung capacity. The inspiratory reserve volume, the expiratory reserve volume, and the tidal volume, however, can be directly measured by the spirometer. And with those 3 volumes, we can calculate the vital capacity as well. So I'll real quickly go back to this picture just to show you once again that when we're getting ready to use the spirometer, we're going to exhale into this tube, and this is going to increase the volume inside of this white box. We've zoomed in here on the scale, and you can see that as we exhale into the spirometer, this gauge is going to move up the scale. This scale is in liters, so you'll have to convert back to milliliters when doing calculations with the spirometer. But you can see that the edge of this gauge is here just at about 1.3 liters. Therefore, since there are 1,000 milliliters in 1 liter, we take 1.3, multiply it by 1,000, and that gives us 1,300 milliliters. So despite its simplicity, the spirometer is an excellent tool, and we can really use it vastly to assess respiratory health. Now, I've already mentioned that when the diaphragm contracts and changes its shape, that opens up the thoracic cavity, and therefore the lungs open up with it. But there's more going on here with ventilation than just the diaphragm pulling the lungs open. Ventilation, that is the movement of air in and out of the respiratory system, is driven by pressure gradients. Just like we saw blood being pushed around in the cardiovascular system based on differing pressures, air will flow in the lungs based on pressure differences that are caused in the lungs by the diaphragm contracting and relaxing. The intrapulmonary pressure in particular is one that we want to look at. This refers to the pressure inside of the lungs, and this pressure is going to change based on what the diaphragm is doing. When the intrapulmonary pressure becomes greater or less than the atmospheric pressure, air will be either pulled in or pushed out of the lungs. Let's take a look at how this works. Boyle's law states that as volume goes up, pressure will go down. These two factors are inversely related, and we will see Boyle's law driving inspiration and expiration. We'll go over inspiration first. So in order to pull air into the lungs, a series of events needs to take place. The first thing that needs to happen, of course, is the diaphragm needs to contract. The diaphragm can be referred to as one of our inspiratory muscles, as of course when it contracts it pulls air in and facilitates inspiration. However, it's not listed on this slide, but we do have another set of inspiratory muscles, and those are the external intercostal muscles. The external intercostals are considered muscles of inspiration, but it's truly the diaphragm that's doing most of the work. So when the diaphragm contracts, that's going to increase the volume of the thoracic cavity. You can see here the diaphragm is jutting into the thoracic cavity, so if this muscle were to flatten out, there's now more space in the thoracic cavity. We want to remember that as volume increases, pressure will decrease. So as the volume in the thoracic cavity increases, the intrapulmonary pressure is going to decrease. When the intrapulmonary pressure decreases below that of the atmospheric pressure, this creates a pressure difference. Essentially, inside of the lungs, the pressure is lower than it is out in the atmosphere. And that creates a pressure gradient, so air will naturally flow into the lungs when the intrapulmonary pressure decreases below the atmospheric pressure. So whatever the pressure is in the external environment, when our intrapulmonary pressure goes below that, that creates a pressure gradient and pulls air into the lungs. Now air is going to continue to move into the lungs as long as there's a pressure gradient. So when the intrapulmonary pressure is back to zero, equal to the atmospheric pressure, that will stop flow of air into the lungs as the gradient ceases. The process of inspiration is facilitated by our external intercostals, but mostly the diaphragm. And it is the phrenic nerve that innervates the diaphragm to allow this to take place. Now, as we've just seen with inspiration, we're creating a pressure gradient to pull air into the lungs. However, we will see that just the opposite takes place with expiration. During expiration, the diaphragm is going to relax, and it's going to move back upwards as it does so. This simple movement will decrease the volume in the thoracic cavity. So specifically, the inspiratory muscles are going to relax. But at the same time that our inspiratory muscles relax, it is our internal intercostal muscles that are our muscles of expiration. So when the muscles of expiration contract and the muscles of inspiration relax, that's going to decrease the volume in the thoracic cavity and ultimately decrease the intrapulmonary volume. When intrapulmonary volume decreases, that's going to increase intrapulmonary pressure. Since we're decreasing the volume and pushing back up into the lungs, the pressure of the air inside of the lungs is going to go up. As the intrapulmonary pressure rises, it's eventually going to become greater than the atmospheric pressure. And now we have another pressure gradient that is set up. Since the pressure inside of the lungs is now higher than the atmospheric pressure, the pressure gradient points back out of the lungs. Just as we saw with inspiration, air is going to flow down its pressure gradient until the intrapulmonary pressure is once again at zero, equal with the atmospheric pressure. So hopefully what we can see is that inspiration and expiration are both driven by pressure gradients. As pressure goes up and down, that's going to form different gradients and allow air to go down those concentration gradients either into the lungs or out of the lungs. One other side note, just to make sure that we're all on the same page, is that our external intercostals are muscles of inspiration and our internal intercostals are muscles of expiration. Make sure that you don't get these confused. Lastly is the phenol red experiment. On Canvas, under the Modules section, you'll find a video linked titled Phenol Red. Phenol red is a substance, specifically a pH indicator. When you exhale into a test tube of phenol red, the carbon dioxide that you are breathing out changes the pH of the substance, and therefore phenol red, which is normally a red liquid, changes its color to become more clear. This is an example of how the waste product CO2 is being exhaled out of the lungs. In the respiratory system, we have a very important buffer system that will help us to carry carbon dioxide in the blood. That system is known as the bicarbonate buffer system, and we can see it shown right here. As carbon dioxide is released from the tissues and put into the bloodstream, this molecule will react with water, and the product of this reaction is carbonic acid. Carbonic acid will eventually become bicarbonate and a proton, and since hydrogen levels will indicate acidity, the more CO2 that we have, the more acidic the blood will be. This will conclude our presentation on the respiratory system. If you have any questions at all, do not hesitate to reach out for help. I will see you all in the next video when we will cover the digestive system.